We will have the discussion now. I'll start with Manikandan. If Puneet Rajkumar had come to you 1 week before his death for an executive health checkup, what would you have done?
We can have a evaluation, but most probably he had some symptoms. He neglected it, and he had a cardiac arrest.
No, he is coming asymptomatic for you for a health checkup. So do you think would you have recognized?
May not be picked up because even 3-vessel disease with 40%, 50% may not be.
I think there Dr. Mugundan's point come. Maybe a coronary artery calcium would have shown the high atherosclerotic burden.
Sometimes we see the ventricular premature complexes in patients with COPD acute exacerbation. What could be the cause for that, and should you do anything for?
In COPD, the ABG abnormalities and also the drugs like theophylline and beta agonist, all these can lead to some incidence of PVC. If a baseline echocardiogram is normal, that PVCs are not going to produce any much harm.
I have a question for Dr. Mugundan. The coronary calcium score will not tell you the diameter, luminal diameter. Is there any correlation studies validating the coronary calcium score with the angiogram?
With the angiogram, it is not there. With the angiogram, only CT angiogram is correlated with the angiogram, invasive angiogram. With coronary calcium scoring, it's only the risk prediction. We cannot say whether the patient has a luminal narrow of 40% or 80% with the calcium scoring alone. But usually we do the calcium scoring and the CT angiogram together. Earlier it was only EBCT, which is not there now. Now it is predominantly CT coronary calcium scoring along with the CT angiogram. For the calcium scoring, we don't require any contrast. For the CT angiogram, we require contrast. So calcium scoring is basically for finding out whether that patient is having a higher risk or not. So above 300 definitely has a high risk. Above 100 also, along with an ASCVD risk scoring, if it is intermediate, you have a high risk. So then you start treatment.
If you are suspecting an obstruction, then the patient, you are thinking about a patient having an atherosclerotic coronary artery disease where it is secondary prophylaxis. Yes. Whereas coronary artery calcium scoring is only for primary prophylaxis. So that tells you the burden of atherosclerosis, not about the hemodynamic significance of the obstruction.
And most of the time CT angiogram is only for detecting it. No follow-up CT angiogram or nothing like that is indicated for secondary prevention.
Mugundan, can you tell us about some controversy, statins and calcium, coronary calcium?
Even if you give statins, the calcium is not going to come down. The only thing is, if you detect the calcium score, calcium above 300, then you can give aspirin and a high dose statin. And you always keep that calcium score and ASCVD risk score together. So for a higher risk group, there is no need for doing calcium scoring at all.
No, my point is patient on statins will have increased calcium score.
Yes, it can, because the inflammatory mediators will be reduced and the calcium scoring may increase. So with the statins, actually, there is no change in the calcium score at all. So it's only for detection as a primary prevention before you start the statins itself. If you have given the statin, there is no point in doing CT calcium.
Statins actually increase calcium scoring, but that doesn't mean that
it's not related to the disease increase.
Any question from the audience? Yes, Binu. Calcium scoring, I think everywhere.
Every CT angiogram, wherever it is done, coronary CT angiogram, multi-slice, it should be 64. Cost is in our hospital, medical college, it is 3,000 only, but private hospital is 10,000 to 12,000.
The calcium scoring is only 2,000, 3,000 like that. I would like to stress one point. This should not be used as an investigative modality in symptomatic patient, particularly when the patient is less than 40 years. It can be erroneous. My question is to Dr. Mugundan, if suppose the calcium score is more than 1,000 in an asymptomatic patient, will you do his angiogram?
No, asymptomatic patient calcium score above 1,000, you need to treat the patient with the statins and this one. There is no need for doing angiogram unless you have a TMT also which is positive. So see the functional and the anatomical together.
If the calcium score is 0, is there a need to go for a CT angio? You can stop the procedure at CT.
In prevention.
One question to Dr. Upesh. In these patients coming with VPCs, what is the role? Is at all there is a role? Is there a role for Holter monitoring or web cardio?
Holter monitoring, if the patient has got any symptoms and if you are suspecting some arrhythmias, then you can do a Holter. PVC burden per se just tell you that you need to follow up the patient. So every patient with asymptomatic or routinely detected PVC, Holter may not be indicated.
VPCs increases on exercise. That is a marker now. So would you advocate routine exercise and repeat the ECG?
If the high risk PVCs are one which usually PVCs decreases with exercise. So if the PVCs are increasing with exercise and if the patient has got any symptom, do a treadmill test. If in treadmill test, if that PVC's frequency is high or if it, complex PVCs appear, then you have to evaluate them further. Otherwise, they can safely exercise. Just a PVC will not prevent exercise.
Exercise is a lifestyle recommendation. If we take two subsets of people, one sports, another one arts. Arts people, unless they indulge in smoke, drink or any addiction, they go on for old age, doing very well. Whereas in sports, most of them stop at 35 or so. Very rarely people like Sachin Tendulkar and Cristiano Ronaldo touch 40. After that, many of them do not do any exercise. They need not. But unless they continue to have moderate exercise, they will also end up in problem. Another thing is, some of them do stop the exercise and come back after a period, then indulge in heavy exercise. That is also a problem.
So any pre-exercise screening recommendations to Dr. Manikandan, please? Nowadays, many people are going for gym and aerobics.
If we are not exposed to any exercise, you are doing for the first time, better to, if you are going for a gym or you are starting high intensity exercise, better to go have a cardiac evaluation, at least look for BP, cholesterol and have an ECG. If possible, do a TMT so that we know there is no significant, if you are not exposed to exercise at all. But if you are regularly exercising and you have no symptoms, you can straight away go for exercise.
Or go to a gym where it is the external defibrillator.
Yeah. Better to go to a gym where there is AED. So that when you have a cardiac arrest, there is small chance of survival.
But Manikandan, most of the sports arenas now it is a must that you should have a defibrillator. I don't know whether it is followed, but I think as per recommendations, most playing arena, sports arena should have defibrillators.
That is why that Europeans in England and Europe, they are surviving. Everybody is surviving, even with cardiac arrest. But here nobody is surviving.
I think two things are there. One is defibrillator and other is teaching of public for CPR. I think we will conclude since we have finished the time. Thank you very much.
Is there time for one more question, please?
Okay, we will have just one more question.
I did a calcium scoring 3 years back and it had been 0. I am not hypertensive nor diabetic. But my 3 uncles, they have undergone bypass cardiac surgery and my LDL is consistently around 150 and I am a power lifter. So what I want to know is that should I be on statins?
Because there is a family history of CAD, you should be on statins. That's what I said. The diabetes, family history of CAD, LDL above 190, familial hypercholesterolemia, there is no need for risk stratification at all. You should be on statins because of the family history of CAD. And calcium score reduces the risks, that's all. And you can do a repeat scoring after 5 years, and that is, both of them are negative, then it is likely that you will have a low risk of events. But with the family history of CAD and 150 LDL, you should be on statins.
Okay, thank you.
Thank you very much, Dr. Mugundan, Rupesh, and Manikantan. We'll go on to the next session.